Accurately staging an adrenocortical tumor dictates a patient's survival, but relying on a manual cross-reference of complex histological matrices consumes critical clinical time. Differentiating a benign adrenocortical adenoma from a malignant carcinoma is difficult because both tumors share highly overlapping morphological features under a microscope. We are going to decode the three primary mathematical models used to navigate this overlap: the Weiss Score, the Lin-Weiss-Bisceglia criteria, and the Helsinki Score. Then we will demonstrate how to automate them. Mastering these models prevents fatal misdiagnoses. Automating their calculation represents the modern standard of elite oncological care. The foundational diagnostic model is the Weiss Score, introduced in 1984. It evaluates specific microscopic features of the tissue to determine malignancy. The system evaluates 9 distinct criteria. The most heavily weighted metrics include a Fermin nuclear grade of 3 or 4, which measures the size and irregularity of cell nuclei, and a mitotic rate of more than 5 dividing cells per 50 high-power fields, or HPF. This reference table shows the scoring system's definitive clinical threshold. A cumulative score of 3 or higher is the strict cutoff indicating an adrenocortical carcinoma. To streamline clinical reproducibility, Albert and colleagues developed a revised Weiss approach. This modified system applies specific mathematical weights to the most reliable indicators, like mitotic rate and the percentage of clear cells in the cytoplasm. For a classical binary diagnosis between benign and malignant, the Weiss score provides an excellent baseline. However, its strict mathematical rigidity becomes a liability when encountering specialized morphological variants of the disease. This coronal CT scan highlights a large 13.3 centimeter left adrenal mass with internal necrosis. This is an oncocytic tumor, a specialized morphological variant packed with mitochondria that requires a different diagnostic logic. This H&E stained pathology slide shows the highly eosinophilic granular cytoplasm typical of these cells. Because oncocytic cells inherently display a high nuclear grade and this specific cytoplasm, applying the standard Weiss score will almost always trigger a false positive for malignancy. The Lin-Weiss-Bisceglia system corrects this error by separating features into 2 categories. Atypical mitoses are major criteria. Tumor necrosis is minor. Under LWB, just 1 major criterion equals malignancy. 1 minor indicates uncertain potential. 0 features classifies it as a benign oncocytoma. By deploying the LWB criteria, clinicians account for morphological mimicry, protecting the patient from overdiagnosis and unnecessary aggressive treatments. Once the initial diagnosis is secure, the clinical priority shifts. The next phase requires accurately predicting the patient's overall survival timeline and the tumor's metastatic potential. To accomplish this, pathologists use the Helsinki Score. This formula strips away subjective variables by combining 3 precise metrics: 3 times the mitotic count, plus 5 times the necrosis score, plus the absolute value of the K67 index, a specialized protein marker that measures cell proliferation. This set of Kaplan-Meier survival curves shows how these scores stratify patient outcomes. There is a sharp divergence between cohorts. A Helsinki score below 13 indicates significantly longer survival, while a score of 19 or above signals a highly aggressive tumor with a worse prognosis. This receiver operating characteristic, or ROC curve, validates the model's predictive power. The data demonstrates that a Helsinki score threshold of 28.5 yields an area under the curve, or AUC, of 0.729. This provides the highest statistical accuracy for predicting disease-related deaths. By integrating the Ki67 proliferation index directly with morphological data, the Helsinki score gives clinicians a highly reproducible, mathematically rigorous predictor for long-term patient outcomes. In a clinical setting, manually calculating Fermin grades, quantifying Ki67 indices, and cross-referencing multiple diagnostic matrices by hand is inefficient and highly prone to human error. The Oncotoolkit Adrenal App is designed to offload this specific mathematical heavy lifting directly at the point of care. The workflow is straightforward. The clinician selects the specific histological features observed in the pathology report. They do not need to memorize the individual weighting or thresholds of each variable. This calculated result interface shows the final output. The software instantly tabulates the total score, applies the correct evidence-based threshold, and outputs a validated risk stratification, in this case, triggering a red warning banner for a malignant adrenocortical carcinoma. This saved results dashboard shows how the data integrates into the workflow. The results can be securely saved with an optional patient ID, timestamped, and exported directly into permanent clinical records. Software automation does not replace clinical judgment. It standardizes the process, allowing clinicians to outsource the arithmetic so they can focus entirely on the patient's treatment strategy.